Thank you.
Respected Professor Ponnudurai, respected Professor Satyanathan, respected President and Executive Committee of Tamil Nadu IPS, Professor Ravi Shankar, Professor Elias, and respected audience. My topic is Artificial Intelligence in Psychiatry, and I am going to discuss this particular topic in three different phases. The first phase, I am going to discuss about the basic issues of artificial intelligence. Second, about applications of artificial intelligence that are useful in psychiatry. And in the third phase, ethical, social, and futuristic issues. It all started with an electromagnetic device called Enigma in the World War period, which was conceptualized by the Nazi regime. Enigma was an electromagnetic device which consisted of rotors, numerals, alphabets, and with an ability of producing more than 1 trillion words. Messages emanating from this device was indecipherable, ununderstandable, like that of our primary autochthonous delusion. Nobody had any clue. Somewhere in 1941 or 42, it was Alan Turing with another electromagnetic device called Bombi. He was able to hack the data and he was able to decipher the message. That was a watershed moment in the computational process, and the development that occurred in the technological milieu in the fourth decades saw a reality called artificial intelligence making inroads in the field of psychiatry. What is artificial intelligence? It is the design and the development of the computer programs to do a particular work that normally require human intelligence. It involves programming of the computers to process an information from data. It may be from input data that could be generated as a meaningful conclusion or output data. There are three types of artificial intelligence. One is narrow AI, and second is general AI, and third is super intelligent AI. Under narrow AI, we have virtual assistant. Virtual assistant is like Trisha in Thug Life. Enna venu unakku, koti koti kedakku. With your voice commands and text messages, it can answer if the answers are available in the knowledge base. It can manage our time. It can manage our automated workflows. Siri, Alexa, Google Assistant, they come under this category. Recommendation system. We have Netflix and Spotify. After 10 p.m., after ensuring privacy, if you are logging into the Netflix, it's quite normal and natural to see a pop-up message emanating from the left side of the monitor as follows. Dear Dash, you had seen 50 Shades of Grey for more than 50 times. Considering your unquenching libidinal thirst, we recommend the following movie, which is very hot, chilly, spicy. That is the recommendation system. And image recognition, we have face analysis. If the artificial intelligence is probably on par with the human intelligence with the ability to take an ethically driven decision or to depict emotions, then it may be construed as general AI. If it is able to surpass the human intelligence, it may be regarded as super intelligent AI. At present, general AI is in the conceptual level and super intelligent AI in the fictional level. When you read artificial intelligence, quite often you come across two words disturbing you: data, algorithm. What is data? It is a collection of raw facts, figures, information that can be processed or analyzed or leveraged. It may be qualitative or quantitative, categorical or dimensional, numeral or textual. And algorithm, it is a set of well-defined instruction how to carry a particular task or perform a particular work. If you are cooking mutton biryani, the marinated mutton and the khichdi sambar rice and the spices are all data. Your recipe is mutton biryani, algorithm. What is machine learning? It is a study of computer algorithm that automatically, through experience, there is a kind of a trained module, and with that I think it is able to identify certain pattern, certain recognition. If such algorithms are not available, it starts looking at the structure of the data and looks for the association factors and the similarities, then it generates output data. It may be supervised machine learning or unsupervised machine learning or semi-supervised machine learning. Supervised machine learning, it acts like a teacher as well as a student. There is an algorithm, I think that really helping the machine to learn. If such algorithms are not available, probably by looking at the association or similarities, it learns on its own. This is the depiction of a supervised machine learning. Imagine in a particular bag, apples and strawberry are there. There is an algorithm, and finally it is segregated into apple and strawberry. Unsupervised machine learning uses different techniques. It uses clustering. Clustering nothing but grouping the data. It may be k-means clustering, which means grouping or segregating the data which are nearest to the mean. Or it could be a hierarchical clustering where the data is generated, grouped from top down or bottom up fashion. Or it could be a random forest in the form of a decision tree. Or it could be a principal component analysis where the complex issues are converted into comprehensible conclusions. Anomaly detection or fraud detection comes under this group. This is a depiction of unsupervised machine learning. In a basket, so many vegetables are there. I think the brinjals are segregated. Then the second level, by looking at other factors, associational or similarities, then each vegetable is identified. In semi-supervised machine learning, small amount of labeled data are combined with a large amount of unlabeled data. And here, apple and pineapples are there. Only one apple and one pineapple was labeled. I think it probably it struggles in the part 1 exam. It just makes a prediction that it could be apple or pineapple. Then with the pseudo labeling, it goes for a trained algorithm at the lower level, and two groups are identified, the first group being apple, the second group as pineapple. So machine learning and the supervised learning, we have classification. Unsupervised learning, we have clustering, and reinforcement learning, we have decision making. Deep learning. For the artificial neural network to process the data, we need to go for the deep learning. For the deep learning to occur, there should be layers more than 2 levels. At each level, imagine a situation where the brain is shown. At each level, level 1, the data is transformed as an abstract code. First layer, I think it is identifying the edges of the brain. At the second layer, I think it is identifying the margins of the edges. Third layer level, it is identifying the gyri and sulci. At the fourth layer, it is identifying the entire structure of the brain. And these are all the mechanisms of deep learning, optimization, dictionary learning, high-dimensional mapping, optimal transport, manifold learning, ordinary differential equation. Natural language process. The computer can analyze and understand the human language, but it can also generate human intelligence, and that is natural language process. The texts that are available from the electronic health record, the texts that are available from the patient transcripts, or from the patient's media post with the emotional tinge, or with a tinge of mental health issues. All these texts are collected in the pre-processing level. Then they are converted into words. This is the stage of tokenization. Irrelevant words are removed. Frequently occurring words are identified. Grammar is focused. Meaning is identified. Then there is a kind of a concatenation to formulate a sentence or a story-like fashion. And finally, with what intent, in what context, the material was written or delivered, that is identified, and it is happening in the 5 levels. One is the lexical analysis, tokenization, texts are converted into words, syntactic, grammar, semantic, meaning, discourse analysis, a sentence is formed, and pragmatic, I think, with what intent and what context it was delivered. How NLP is detecting depression. You know pretty well a depressive person in the negative cognition may be uttering certain words like, I feel so down and tired, I guess. The language mechanism, it is identifying that there is an increase to first-person pronouns, increase to negative valence, and decrease to positive valence. At the next level, the acoustic process, it identifies that there is a decrease to speech rate and decreased intensity variability and increased responding reaction time. So it should be depression. And these are the applications of NLP in communication. Chatbots, we have Visa, Obot, Replica, and Uper and Tessa. Voice assistants like Apple, Siri, Alexa, Google AI, and sentiment analysis for emotional aspect, and text summarization for comprehension. Language translation is a little difficult. A word like schizophrenia has to be translated in language like Tamil, and people say Manachidaivu or Mana Adarchi may be very dearer to heart of the people who are well versed in Sangam Tamil. But imagine schizophrenia to be explained for a person who speaks Madras Pata language. Madras Bhasha, it consists of English word. Right English words are used in the wrong intention. Correct is the exactly right word. Correct panitina set pantiyan artham. So, schizophrenia cannot be really, translated in one word. Or probably our obsessive compulsive disorder. Thirumba thirumbas. Ninichi thirumba thirumba. Seiradhu, idella probably, it's better to go for transliteration rather than translation. MBBS MBBS na ezhudinu irukom. This is little difficult. And second, last one is the personalized recommendation. What are the digital tools of NLP? Visa and Obot for CBT, MindStrong for sentiment emotional analysis, crisis text line whether the suicide risk, whether the notes written by the patient, whether it's positive for suicide or negative for suicide, and empathic AI models for diagnosis, and meditation journaling for personalized interventions. How AI is making a diagnosis with the electronic health records, by observing the facial expression, by undergoing or reading the text and focusing on the speech, early signs of mental illnesses are identified. Looking at the genetic issues, focusing on the environmental factors, and concentrating on lifestyle methods, assessment of risk is made. How AI is useful in treatment? With the patient's history and the behavioral pattern, and a trial and error method, personalized treatment plan, it is minimized. Imagine a depressive individual, we need to start an SSRI, and we have to wait for 2 weeks to see whether the particular molecule is exhibiting or exerting any kind of a beneficial effect, and for that he has to come for the review after 2 weeks. He may not come. He'll be continuing the same molecule for 6 months and come with pharmacological mania. Here, the trial and error method, duration is decreased. And AI-driven chatbots, virtual therapists, and therapists, they provide accessible, inexpensive, less stigmatizing mental health support. AI monitoring. The patient's history and AI applications, they continuously monitor sleep status, cardiac level, and activity. And with the assessment of risk, one can really initiate proactive treatment. Supervised learning algorithms, especially the support vector machine, the random forest, I think they identify diagnostic categories. With the clustering techniques, we can identify patient subtypes. Reinforcement learning, though it is rare, I think just-in-time adaptive intervention, JITI, I think we can adjust to patient responses. Coming to deep learning, convoluted neural network with the neuroimaging data extract spatial features associated with the psychiatric disorders. NLP can detect symptom patterns, sentiment, and semantic structures. Speech analytics with acoustic mechanisms, with the prosodic analysis, they can identify markers of mood and thought disorders. With the multimodal signals and neuroimaging EEG and wearable sensor data, functional MRI, they help in pattern recognition. How multimodal signals help in diagnosis. With the patient's history, lab results, MRI findings, EEG details, and assessment of activity, along with the AI models, we can make a diagnosis. The ability of AI making a diagnosis is on par with the human expert, but it reduces the variability. And it helps to formulate uniform treatment protocols, and also it avoids common medical dangers. NLP tools, by analyzing the speech and written language, they can identify linguistic markers of depression and cognitive decline. Speech-based models, they can detect psychosis, and multimodal models can differentiate whether depression is part and parcel of a bipolar disorder or just it's a major depressive disorder. This is how predictive analytics is conducted. We have data over a period of time, and reporting analysis, what had happened, what was the cause for this problem, that is looked into. And in the monitoring level, what is happening now? And what will happen or what is going to happen, that is the predictive analytics. And so action is initiated in order to really, retrieve the previous psychological equilibrium. Predictive analytics, they can predict effective treatment for effective individuals, specific individuals. And ML, machine learning, can also identify indicators that precede relapses so that tailoring the treatment in a proactive manner is possible. And with the wearable sensor data, like monitoring sleep and activity and cardiac status, BPD, bipolar disorder, may be identified. Looking at the baseline clinical features and the genetic issues, one can identify, analyze about the antidepressant response. By learning the patient engagement symptom trajectories, one can optimize cognitive behavior therapy protocols. With the proteomic analysis, differential protein expression profiles in mood disorders are identified, even related potentials like electrophysiological biomarkers of cognitive dysfunction identified. With the personalization algorithm, it's possible to really formulate personalized treatment pathways. There is a pessimistic argument in the initial phase of artificial intelligence that AI would not augur well in the field of psychiatry, because psychiatry, one has to really develop an attitude called empathy, and and engaging the patient is also a little difficult, and these machines cannot do this. But contrary to this belief, argument, the conversational agents or chatbots, they spend more time than the human expert. Either in the interviewing process or in the therapeutic interaction, the conversations are so naturalistic and so therapeutic. And we have exposure therapy. Excuse me. We have exposure therapy with the virtual reality and augmented reality. Virtual reality is nothing but creating a simulated environment, and augmented therapy, reality, is probably an addition of an object or a subject or a computer-generated percept. In a traditional behavioral treatment, the therapist is asking the patient who has fear, why don't you reimagine your threatening stimulus and also re-experience the fear? At the time of re-experiencing the fear, it may not be appropriate, it may be more than that or lesser than that. But what is an advantage of the virtual and augmented reality therapy? One can create the same kind of environment with the same kind of a threatening stimulus, and if the response is fearful, response is going beyond the level of the patient, there is a controlling mechanism with the patient as well as the therapist. And this is one advantage. How chatbot works? There is an input reception. Usually, we always send a message or a voice command. Then there is a natural language process. Tokenization is there. Next level, I think this is analyzing whether this is an inquiry or a request. And if the answer is available with the knowledge base, it answers. What are the various chatbots in psychiatry? We have Gmind LAMP. LAMP is an acronym for Learn, Assess, Manage, Prevent. With the use of the smartphone and the sensor data, one can really know the experience about his mental illness, and coupling this detail with the GPS and exercise, one can predict the recovery of the mental illness. BiAffect is another chatbot which can categorically say whether this individual is in bipolar depression or bipolar mania, and this mixed picture category may not be there. At Wobot, it monitors symptoms of anxiety and depression by challenging the cognitive distortions, arbitrary inference, maximizing, catastrophizing, Martin Seligman's permanence, personalization, pervasiveness. All these cognitive distortions are challenged. Replica. This is the most widely used chatbot in the last 5 years in the American milieu to conduct research for romantic relationship, sexual experience with real partners, and sexual experiments with sex robots. What is happening here? In this particular chatbot, one is to make a conversation about himself. Second level is painful, and he has to listen to the conversation about himself. And sometimes in the World Psychiatric Conference, you are the speaker and you are the audience. The session hall 74 may be 2.4 kilometer long, and the Similarly, the person has to make a conversation about himself and he has to listen. And it is suggested that a person, by listening to his own conversation about himself, subconsciously or consciously, it's possible to improvise the positive qualities and easy to really get detached from the negative qualities. And Paro is a chatbot, ideal for the demented patients who feel extremely lonely and isolated. And it also helps autistic children. And Apple Siri, it has more patience, tolerance, not clients. And it can really spend more time than the human expert. Caspar robot, that's for autism. It's a provoker, reinforcer, trainer, mediator, prompter, diagnostic information provider. It acts like a social mediator, helping children to better interact and communicate with adults and other children. ChatGPT, it provides emotional support where the professional therapy is inaccessible or extremely expensive, it helps. It provides general mental health advices, suggests coping strategies, and guide users through calming exercises. And this is about AA and schizophrenia. How AA is useful in schizophrenia. 1. Multimodal signals, linguistic behavior analysis, machine learning applications, and adaptive learning, and self-optimization. With these 4 processes, diagnosis of schizophrenia is made. What are the advantages? 1. Early identification. The duration of untreated psychosis is reduced. Second, psychiatry is criticized that it is based on a reliance on somebody's subjectivity or objectivity of somebody's subjectivity, or again therapist subjectivity is there. This is confronted here with the multimodal integration, objective evaluation. This is an advantage. And not only that, it is an individualized diagnosis. Coming to treatment of schizophrenia. Assisted dosage adjustment, continuous dynamic monitoring, and urgent psychotherapy, a drug research and development, a treatment is initiated. Long-term prognosis is predicted. Sometimes you are faced with an embarrassing question, sir, lifelong or sir? Matra, nama life, our life, such questions may be really no answered. Second, the functional recovery prediction. You know, the recovery is 3 types. One is the symptomatic recovery, the improvement of symptoms. Functional recovery is ability of an individual to go back to his occupational milieu and start working with the same efficiency as he executed before the onset of illness. I vividly recollect one incident in Institute of Mental Health. A cop was admitted in a ward and he was a burnt-out schizophrenia. And 10 days we were treating, and they were the relatives are pestering, sir, discharge pannunga. I consulted my chief, and chief asked me to discharge the patient. We used to write our last sentence. Send work report within a month. The work report may come within a month in very rare cases, or it may come after the retirement of the worker or the person who had written the discharge sheet. And we discharged the individual. 3 days later, he was posted to the outpost of IMH, police outpost. And the next thing, every morning by 5 o'clock in the morning and 5 o'clock in the evening, he used to pass urine. Pass urine, no, he was passing urine right in front of the male duty doctor's room. And this was happening continuously. Again, my chief asked me to contact the higher official. Or சீக்கிரம் வேற எங்கேயா ட்ரான்ஸ்ஃபர் பண்ண கேளியான்னு நானும் கேட்டேன். அங்கே ஒரு பதில் வந்துச்சு, நீங்களே அவனை வச்சுக்கலன்னா நாங்கள் எங்கே போய் அவனை வச்சுக்கிறது. We failed to assess the functional recovery at that time. Probably AI will avoid such incidents. And also there is another advantage of relapse risk assessment and dynamic adjustment. And prognosis of schizophrenia. This is individualized to prognostic assessment model. I think long sight is better than short sight. Identification of prognostic factors, deep learning based data integration, recurrence risk prediction. The prognosis is made. The advantages are personalized treatment plan, dose adjustment, optimization of drug selection, and prediction of treatment response. Language analysis. They focus on the semantic coherence and syntactic complexity, and probably they predict the possibility or probability of developing psychosis in at-risk population. And platforms such as LAMP, AWARE, CrossCheck, they continuously monitor the subjective and objective markers of psychotic relapse. A in addiction. CHESS is an acronym for Center for Health Enhancement System Studies. Imagine a person, alcoholic, was treated, he is in the abstinence period, he goes for shopping, he is somewhere near Taskmark or liquor shop or bar. There is a message may be emanating. Bro, you are nearby liquor shop. Move out of this place. He has to listen. Suppose if he starts giving importance to his craving, the next message, உங்கள் பையன் ஸ்கூலுக்கு வரலன்னு மெசேஜ் வர்றதில்லை சில ஸ்கூல் மாதிரி. bro அங்க இருக்காரு அப்படின்னு சொல்லிட்டு the dear and near will get a message. Third level, I think, in the clinician dashboard, immediately the therapist or the counselor will come and advise. தம்பி ரொம்ப தப்பு பண்ற. So this is very popular in American milieu. And in addiction, CBT, in the abstinence period, how far it is beneficial, that was evaluated on particular research. And REN and DREN optimized behavioral risk quantification. In personality disorder, again, replica may be used in borderline personality disorder, and it is probably claimed that by listening to their own conversation. நான் சொன்னாலும் ஒரு படத்தை சொல்லுவார்ல ஹீரோ, நான் சொன்னதா கேட்குறேன், என் பேச்சே நான் கேட்க மாட்டேன்னு. Probably there are exceptions. But it is believed that listening to the conversation about himself, I think the borderline people, they start showing some improvement in the social and emotional milieu. It is very difficult to diagnose depression in childhood, but one can forecast depression. And with the support vector mission algorithm, ADHD can be predicted correctly to the extent of 88.7%. In geriatric psychiatry, with the machine learning method, aberrations in recall, aberrations in executive function, aberrations in the visual spatial features are the three distinguishing features between Alzheimer's dementia and minimal cognitive decline. And if a suicide note is there, whether it is positive or negative, that can be correctly predicted by AI. Then we have cyber therapy, as I already mentioned, that you are able to create and control the situation. And learning virtual social interactions reduce paranoia in psychotics. One particular randomized control trial is there. VR exposure treatment facilitate follow-up, mindfulness, relaxation, and self-compassion may be learnt in VR. This is the virtual reality. You need to have a headset, camera, high-tech computer, and high-speed internet connectivity. And probably you are in a simulated environment, and the experience is really immersive. And augmented, I think there is an addition of a computer-generated percept. Imagine a person with a phobic tendency for spiders, arachnophobia, is entering a psychiatrist's clinic. Immediately is given a headset. He or she starts visualizing the spider and starts responding in a fearful way. Then there is a controlling mechanism with the therapist as well as the client, and so behaviorally I think is improving in a systematic or gradual way. Our fear of flying, with the same headset, he can see the airport. Then he is entering the airport, checking in, entering the plane, occupying 11A seats. அது புக் பண்ணியிருக்கிறான் அகமதாபாத்துக்கு அப்புறம். Probably in the taxiing of the flight, he is perceiving, then taking off, he starts harboring the fear, and that is being controlled with the therapist. Controlling mechanism is with the therapist as well as the client. And this is augmented reality therapy with the digital image. There is a cockroach shown in the monitor, and probably his fear is reduced. And this is augmented reality therapy for CBT with the digital image. I think with the acoustic issues, I think even the post-traumatic stress disorder trauma, that also can be created. And these are all the VR applications in mental health. One is limbics for fear, addiction, mindfulness, Knox-4 for anxiety, psychosis, and fear of heights, CS for biofeedback, mind coating to quit smoking, and digital phenotyping. Before that, we must know about the biomarkers. About the unique feature of psychiatry, its absence of biomarkers. Biomarkers is a clinical sign in a medical condition that can be accurately or reproducibly measured. Such things are not there. There is no symptom-specific disorder in psychiatry, so we switched over to phenotypes in the digital way. So where we collect these phenotypes? From activity, geolocation, the keyboard, the style of scrolling the keyboard. சில பேர் அப்படியே அடிப்பாருப்பா. Ambidextrous, நம்மளாம் ஒத்த விரலுக்கு ஒரு விரல் கிருஷ்ணாராவ மாதிரி ஒன்னொன்னா அமைக்க இருக்க வேண்டியதாக இருக்கு. The speed they type, even the voice commands. the prosody. Everything is looked into. And these are all the domains from which we get the phenotypes. Cognition, mobility, voice, activity, survey, sentiment, emotions, and sleep. And these are all the various parts of a smartphone. We have camera, microphone, light sensor, temperature sensor, humidity sensor, pressure sensor, accelerometer, proximity sensor, gyroscope, near field communication, Bluetooth, touchscreen, fingerprint identity sensor, GPS, and magnetometer. And from keyboard, we get the phenotypes. One is the coordination, impulsivity, concentration, and reaction. From the accelerometer, we get activity, psychomotor dysfunction, sleep. From the phone, we get the prosody, speech volume, coherence, and social dynamics. From the text log, suicidal ideation, social dynamics, and connectivity. From the GPS, we get details about sleep or how far the person is connected to the social milieu. Digital phenotypes are useful to detect early changes of depression, schizophrenia, and post-traumatic stress disorder. Self-harm for predicting suicide is also possible, and anomaly detection for relapse of schizophrenia. And closed-loop intervention, JITI, just-in-time adaptive intervention. Smartphone may infer low mood, poor sleep, and recommend intervention. And these are the digital health technologies in mental health. Digitally delivered psychological therapies for self-management of depression, anxiety. Smartphone data may be active or passive, so it may be useful to track mood, lifestyle in major depression, bipolar disorder, and psychosis. Social media for calculating the population and level monitoring of mood and anxiety. Virtual reality for exposure therapies, and chatbots for individualized therapies. What are the positive and negative views about digital usage? On the positive side, it provides rich data to mental health professionals, enhances established services, and promotes retention with other mental health services, and 24/7 accessibility to support. And it is a stepping stone for people who really harbor some kind of fear or anxiety or inhibited to go for face-to-face therapy. On the negative side, it promotes non-human support, can create a digital divide or exclusion. Digital literacy should be there. And there is an increased use of screen time, which may be detrimental to mental health. And digital data may be exploited. Some digital interventions like chatbots provide pseudo-empathy. And these are all the AI applications. With deep learning, we can classify mental patients based on fMRI images. With unsupervised machine learning, we can discover phenotypes in passive data. With supervised machine learning, we can find association between biomarkers and anxiety. With the text summarization, we can summarize the patient notes. The time is reduced. And question answering at raw knowledge data. And the machine translation facilitate communication with the patients. And in the digital health, with a wearable device, health tracking is possible either with a smartwatch or a smartphone. And smartphones find associations between smartphone use and psychiatric phenotype. And digital interventions suggest mental health interventions when symptoms are detected. AI is not complete without talking about sex. Samantha is the first sex robot, and Henry the first male sex robot. And the literature, I think, using of sex bots, I think there are positive and negative consequences. Design based on opinions of human users. And there is a male bias in design, interaction, and ethics. Sex bots for sex. Some people say, no, it's for companionship, it's for friendship, probably fantasy, stereotype, mostly female figures. And question of pedophiles. This is another Pandora's box. I have a question to Dr. Suresh Bada. A person using a child's sex bot, and probably he is not disturbing any other person. And will it be construed as a pedophile? Or person who is really masturbating in a thought level is thinking about a 17-year-old female? Or most of the heroines that are depicted in the first movie, I think they are Sweet 17 only. So POCSO Act would be really implemented, or what about these people? I think, but again, this is a Pandora's box. Interaction is becoming more realistic. But there is a projection by 2030, 52% of the Americans could have experimented sex bots. Interaction is becoming more realistic, which can affect human perception. There is a new sexual violence with AI. AI-generated image-based sexual abuse. If you have a photograph of somebody or video running for a very short duration, say 1 second or 1.5 seconds, I think that can be nudified in certain websites. And probably if you don't like somebody, or if you are in a relationship and everything, and start feeling that the relationship had become toxic and you want to really, settle scores, there is something called revenge porn. This is happening, including Tamil Nadu. On the other side, there is a big business in the porno side. Celebrities' photos are nudified and probably they are selling at a very premium rate. There was a review of literature from 2020 to 2025 with reference to artificial intelligence influence in sex. The bottom line is the concept of pleasure is neglected. Sex is a kind of an experience, but after the introduction of AI, sex has become an experiment. And customized chatbots and pornography opens the door to more diverse, inclusive, queer, feminist, and kinky sexual fantasy material that could complement traditional heteronormative male-centered pornography. What are the legal issues? It has to be in tandem with the Information Technology Act 2000 with the amendments. There is a provision in Mental Health Care Act 2017 to protect the details of the patients. So digital data, how they are going to protect, this is a $1 million question. And it has to be in tandem with the Health Insurance Portability and Accountability Act, General Data Protection Regulation, GDPR, and if you are devising a particular digital intervention, I think ICMR has guidelines for using AI in healthcare. What are the ethical and social considerations? Data privacy, how they are going to really, keep it in a secured mode. And consent, at the time of getting informed consent, whether it would be really any assurance would be given to the layman who is giving his data, that it would not be used for any kind of a potential risk. And there is an algorithmic bias. Metadata available from a particular demographic population in a different culture that cannot be generalized. What are the bias mitigation strategies? It is said that there should be periodic auditing of the data. And smaller data, I think it should be merged with the bigger data. And there should be data augmentation procedures like transformation of rotation, flipping, scaling, and color augmentation. What are the futuristic issues of AI? I think this is the time the future and the present psychiatrists need to upgrade their digital literacy. I think AI is really going for leapfrogging in psychiatry. If you are not really in tandem with the speed of the AI, I think we have to remain like a frog in the well. And consider young user in the development of digital mental health intervention. For anything and everything, there is a device. But the end user should be considered at the time of really, developing it. And it is available only in certain websites. In application purchase. Buying a Mac is costly. Buying a Microsoft software for Mac, it's like marrying at the age of 60 and maintaining a woman. Very, very difficult. It's costlier than the Mac's price. So I think it's better to really, have all these digital devices, the common man's smartphone, commercial smartphone. Right now it is just available to the extent of 1%. And there should be a network, ensure quality, foster connectivity, and patient should have the ownership of the data. And if he comes to know that he has got a psychological problem, there should be facility, avenues to seek help either from the private side or from the government side, or even to go for a tertiary care unit. And it should be tailored to individual needs. AI is not a mirror, but a lens, a companion to discern, detect, and illuminate. It's neither healing nor healed. It's neither solace nor suffering. It is an interaction, it is a bridge between knowing and not knowing. From the predictive analytics to the conversational companionships, AI is not a substitute for empathy, but it rendered its craft to those who had been lost in the margins of suffering. It is an instrument of understanding, not an architect of judgment. It is a tool of foresight, a sentinel that keeps data without any fear. It never fears nor forgets, but yet it serves. The future may ask some questions. Can AI predict the pathway of hope, or will it just trace its outline? Can AI illuminate the hope, or it will just map its terrain? The answers lie not with the digital device, but with those who wield it. Then there is another bigger question. Artificial consciousness. One word, if artificial intelligence is doing, artificial consciousness is being. It consists of subjective experience. How I'm able to really depict my emotions, qualia, and self-awareness, my existence, my identity, how I'm able to get connected to the social milieu, how far I'm able to take a decision, how far I'm able to take a meaningful decision and interaction, and with strategic thinking. Still, it is a theoretical possibility. I think the brain activity with a reference to subjective experience, it is still elusive to neuroscience philosophers, AA, and psychiatrists. I would like to recite the verses of Kannadasan. பிறப்பின் பயனது யாதன கேட்டேன் பிறந்து பாரென சொன்னான் இறப்பின் பயனது யாதன கேட்டேன் இறந்து பாரென சொன்னான் அன்பின் பயனது யாதன கேட்டேன் அழித்து பாரென சொன்னான் அனுபவித்து வாழ்வதுதான் வாழ்க்கை என்றால் ஆண்டவனே நீ எதற்காக என்றேன் ஆண்டவன் சற்று அருகில் வந்து என் காதோரம் சொன்னான் அந்த அனுபவமே நான் தான் என்றேன். Unless until I think artificial intelligence probably touches this particular aspect called artificial intelligence, the final word is still elusive. In one word, I would like to conclude one sentence. Artificial intelligence is a travel guide, but not the travel. Thank you very much.